Yes.
Yes.
Okay. So good morning, everyone. My name is Débora Barbosa Rocha Ribas, and I'm a medical student from Faculdade de Ciências Médicas de Minas Gerais, in Brazil. It's an honor to be here at the 6th International Keloid Symposium. And before I begin, I'd really like to thank the organizing committee for the opportunity to share our work with such a distinguished audience. And it's a privilege to contribute, and I really hope that our findings can add something useful to our conversation today. So this study is the result of a collaborative effort, and I'd like to introduce the team behind it. Alongside with me, there are Maria Eduarda Barbieri Horta, Sofia de Carvalho Leal, Dr. Luciana Nassif da Costa Vale, and I'd especially like to acknowledge our senior author, Dr. Gisele Viana de Oliveira, whose work on the ASAP algorithm forms the foundation of this study and who guided our research. So, on behalf of all my co-authors, I'm honored to present our study on the clinical efficacy of the ASAP algorithm, a prospective cohort study of 141 keloids in 77 patients. First, the formalities. This is an original research. The study was approved by our institutional ethics committee, and all procedures were consistent with the Declaration of Helsinki. And there was no funding for this work. And Gisele Viana reports relationships with Vidance and LMG, but the remaining authors declare no conflicts of interest. Now, let me start with the background. As everyone in this room knows well, the keloid disorder is one of the most challenging conditions to treat in dermatology. That's especially because they recur frequently after treatment and they can cause real physical and psychological burden for our patients. So, a central problem in that is that single modality treatments often fall short. So, it was precisely this gap that motivated the development of the ASAP algorithm. It was designed by Dr. Gisele Viana de Oliveira in Brazil, and it is a rational, sequential, multimodal, and non-surgical approach to treat keloids and hypertrophic scars. So the ASAP algorithm is built on four, on four sequential steps, and the acronym itself describes them. The first A stands for assessment of the lesion, which is a careful characterization before any treatment begins. The S stands for soften. It's made using occlusive dressings to reduce the tension and hydrate the lesion. The second A, which is really the big therapeutic core of the protocol, stands for approach. And we do it combining advanced energy-based technologies with intralesional injectable antifibrous and drugs. And those components can work synergistically to make a better result. And finally, the P stands for pigmentary alteration treatments, addressing the pigmentation that commonly come with the keloid lesion. And what I'd like you to take from this is that each step of the ASAP protocol targets a distinct mechanism of the keloid biology. So that's the rationale behind the sequential and multimodal design of the ASAP algorithm. However, the protocol it's constantly evolving. So the protocol was recently revisited and it was published this year in 2026 in Clinics in Dermatology. And the updated version of it also includes microneedling and pharmacotherapy, for example, with verapamil or toxinobotulin, and picosecond laser to address the hyperpigmentation. With that background in place, our objective was really clear and focused. It was to evaluate the clinical efficacy of the Brazilian ASAP algorithm to treat keloids in a real-world clinical setting. Now we go to our methods. This is a single-center prospective cohort study. It was conducted in a dermatology outpatient clinic between 2022 and 2026. Being prospective, the patients were enrolled and followed as they progressed through the ASAP protocol. Our inclusion criteria were really straightforward. We include patients of any sex, aged 18 or older, with the clinical diagnosis of keloids, treated according to the ASAP algorithm at our primary study center between 2022 and 2026. So, on the other side, we applied clear exclusion criteria. They are summarized in this flow chart, and the patients were excluded if they had been treated at another institution, if they had attended fewer than 3 visits, if they were under 18 years of age, or if they had not signed informed consent. After applying both inclusion and exclusion criteria, our final analytical sample consisted of 141 keloids across 77 patients. A few important methodological points about how we analyze the data are shown here. Our primary unit of analysis was the individual keloid lesion, and this was a deliberate choice because a single patient may carry several keloids and each of them may behave different from one another. So sex and age, however, were reported per patient as unique counts because we wanted to avoid the double counting of the individuals who had multiple lesions. Also, we also defined the complete resolution as the full flattening of the keloids. That's important for the rest of our presentation, so keep that in mind. And lesions that had unavailable or insufficient follow-up data were excluded from the efficacy analysis, and that left us with 109 lesions with evaluable outcomes. Now, as for the statistical analysis, to examine the associations between categorical variables, we used the Fisher's exact test. This is the appropriate choice here because we had expected small counts in some of the subgroups. And to compare the continuous variables between the groups, we actually used the Mann-Whitney U-test, which does not assume a normal distribution. Let's now turn to the results. We're going to begin with who our patients were. Our cohort was predominantly female, with 55 patients, which represents 71.4% of the patients, against 22 male patients, making up to 28.6%. The mean age was 38.3 years, with a standard deviation of 13 years. And there was a notable wide range from 20 to 81 years old. This female predominance shown here is consistent with what we see in the clinical practice of the typical profile of keloid patients seeking treatment. And this broad age range shows that actually the protocol was applied across a wide spectrum of patients. Now, this table, table 1, summarizes the characteristics of the 141 lesions. Looking first at the anatomical location, the most affected sites were the anterior trunk with 21.3%, the posterior trunk with 17%, and the ear at 14.2%. What stands out in this case is actually the anatomical diversity, because the keloids were distributed widely across the body, and that's what we actually see in our clinical practice. Now, turning to etiology, in the lower part of the same table, we can see that surgical trauma was the single most common identified cause at 24.8%, followed by acne at 23.4%, and piercing or earring trauma at 14.2%. And now we are going to our central efficacy results. In table 2, among the 109 lesions with evaluable outcomes, 42 lesions, and that's 38.5%, achieved the complete resolution. The remaining 67 lesions achieved partial resolution. But looking at the treatment duration, the mean was around 12 months in both groups. But there is a finding that I'd really like to emphasize, because we realized that treatment duration did not differ significantly between the complete and partial responders, because the Mann-Whitney test gave a p-value of 0.66. And in plain terms, this means that the response quality was not determined simply by how long the patient was treated. Now, this next slide addresses the impact of laser therapy on outcomes, and it's one of our most important results. Because among of the evaluable lesions, the complete resolution was achieved in 42.3% of those treated with laser, and this is compared with only 8.3% of those treated without the laser. So this difference reached statistical significance with a Fisher's exact p-value of 0.027. And we have to admit that the estimated odds ratio was large, around 5 to 8, depending on the correction applied. But I'll be transparent that the confidence interval is wide because of the non-laser group was small, but the direction of the effect is consistent and really clear. And the bottom line of that is that complete resolution was significantly more frequent when laser was part of the treatment. We also we also explored the outcomes by anatomical region and by cause. By region, ear keloids were the ones that achieved the highest complete resolution rates at 66.7%. However, by etiology, the keloids related to piercing or earring trauma responded the best at 64.3%, followed by the acne-related keloids at 53.6%. While the keloids from surgical trauma, they actually resolved completely, much less often at 26.9%. And I want to be clear that these findings are only exploratory due to the small groups, but they can be hypothesis generating findings, and because the patterns are clinically coherent and they are worth noting for further studies. Now, turning to safety, the profile here was very favorable. Adverse events were documented in just 9 lesion events occurring in 6 patients. So that's 7.8% of our cohort. These adverse events consisted of pain in the injection site, pericortitis, intralesional corticoid depot, ulceration at injection site, and corticoid-induced dyschromia. And for a multimodal protocol like the ASAP protocol, this is actually reassuringly low, and the adverse events appear to be really manageable, and that shows a really nice safety profile for this treatment. So now to bring the numbers to life, here are some representative clinical results. This is figure 2, keloid on the posterior trunk. It was shown before and after the ASAP treatment. And here in this picture, you can appreciate how the visible flattening of the keloid. Here it had the really high borders, and here we see a big flattening of the keloid and an overall improvement of the lesion. And here in figure 3, we have an auricular keloid. And again, before and after the treatment with the ASAP algorithm. And here we can see notable and significant improvement. And we can almost say that the lesion almost disappeared here. So let's now move it on the discussion. The first key point concerns the treatment duration. The fact that it did not differ between complete and partial responders is, I believe, a clinically relevant finding, because the practical implication for this is that simply extending the treatment duration without optimizing the therapeutic approach is unlikely to convert partial into complete responders. And in other words, this means that what we do appears to matter more than how long we do it. The second, and perhaps the most important analytical finding of our study, is that statistically significant association between the laser use and the complete resolution with a p-value of 0.027. Because this is reinforced by what we saw in the group treated without laser, where responses were almost exclusively partial, over 90% of them. And taken together, this strongly supports the inclusion of energy-based modalities as a central component of the protocol, rather than just an optional add-on. And that speaks directly to the synergistic philosophy of the ASAP algorithm. So no study is without limitations, so I'd like to address ours openly. First, it is a single-center study, which may restrict external validity. Second, there was no randomized control group, but that's something that we intend to address by adding a control group in the next phase of our research. Third, we relied on clinical documentation rather than a validated quantitative SCAR instrument, such as the Vancouver SCAR scale. But we plan to incorporate such tools going forward in our study. And finally, some lesions were excluded due to incomplete follow-up. So for all these reasons, we believe that future multi-center randomized studies with standardized outcome tools and longer follow-up are warranted. Now, let me bring this together with our conclusions. First, the ASAP algorithm achieved complete resolution in 38.5% of the evaluable lesions. Second, with a mean treatment duration of 12 months, our data pointed to the primacy of modality selection over the treatment length. Third, the laser-assisted therapy was associated with a markedly higher complete resolution rate rather than the non-laser treatment, with 42.3% versus only 8.3%. And fourth, the protocol showed a great safety profile with adverse events in only 7.8% of the patients. So taken together, these findings support the ASAP algorithm as an effective, well-tolerated, and reproducible non-surgical strategy for the management of keloids. And importantly, they also provide a robust empirical foundation for the prospective randomized validation that we believe should come next. This work builds up on the published ASAP algorithm referenced here, and I really like to thank you all once again for your attention.
Well, thank you very much for your presentation. And does anyone have any questions? Oh, 2 or 3. Just talked about resolution, and then they said we'll do that.
Thank you very much, and thank you, Dr. Oliveira, being here for us. You have 2-3 more presentations. Are you going to describe the process of treatment and what this treatment is exactly, and this 11 months that the patients are receiving treatment, what are they exactly receiving, or shall we ask the questions here? Yeah, good. Perfect. Thank you very much. Yeah, she's going to have a presentation tomorrow, correct? And we'll go through that. So the other question I had, if you go back to your second or third slide, it was that you had the algorithm as to how many patients you excluded. This study, the IRB approval was approved before you started treating the patients, prior to treatment of the patient. How many patients were treated before you excluded some of them? Can you go back to that slide that you had at first? Do you know?
It was over 300 patients. The RIB was approved, we treated the patients, and then we applied our inclusion and exclusion criteria to end up in our statistical number.
Yes, so Deborah, first of all, thank you so much for presenting. I'm very proud of you as my students. Deborah is a very bright student. We published together 3, she's been in 3 of our studies, and she's a great student, and hopefully she will go into dermatology and stay with us. So anyway, thank you, Deborah. But what happened is that in this project, we have now actually a prospective study going on for all of the patients that come to my clinic. So sometimes they sign up for the informed consent to participate on the study, but I should mention that Brazil is a continental country, and many patients are, actually that nowadays patients go to the internet to tell what they think about their treatments, and we are receiving many patients from distant cities. So sometimes the patient comes and they sign up for the study, but when they realize they will have to be back at least once a month, they don't want to continue the study, and so we cannot take them, as participants of the study. So the problem with this algorithm is that it does require continuous, coming back of the patient has to be back at least ideally each 15 days when they live nearby, but at least once a month. So one of the patients, for instance, that Deborah has shown, that I actually wanted for her to come because I think it's important that we show the flaws of our algorithm, is that it requires so much from the patient that sometimes, it's difficult for them to be back and to do the whole thing. And that particular patient lives in Brasilia, which is a city like maybe 1,000 kilometers from my city. She has to take a bus. She doesn't have a lot of resources. And so that's delaying her treatment. If the patient, and this is the second thing that we are going to evaluate, because if the patient comes each 15 days, we have found in preliminary data that the approximate time that it's going to take to, and of course, keloids are different, but it's going to be 1 year. But if the patient delays and can just come back for injections and lasers each 3 months or 4 months, And so that was actually, when I look at those numbers, when Deborah, submitted it, and I should say that everybody leaves everything to the last minute, but when she submitted, and I sit with them before it's presented to check on all the data, I realized that they actually included a lot of people that applied to the study, but they didn't actually come to do any treatments whatsoever. So, of course, it should have been stated during the study submission in a different way. We have a lot more patients also to analyze. I just allowed for the students to present what has been strictly analyzed, and we've been back to all of the protocols, all of the charts, and fortunately they are our patients, so we have it all figured out and well written, but that's the difference. Anyway, I think it's great, a great preliminary report. We have to work a lot on that before we do any publications of that, but anyway, just to thank Deborah and all of you for your attention. Thank you.
Well, thank you. Could I just briefly ask a question? I noticed you talked about resolution being flattening. And what I'd like to ask is, how long after the completion of treatment did you actually measure this?
Right. So we don't think that resolution is just flattening. That keloid, for instance, that was almost flat is far from resolution. Resolution, what I see is that it has to be flat with no erythema. It has to be really, tomorrow I'm going to show some cases where when I realize, okay, this is done, and this patient doesn't need any other treatments. While some erythema remains, especially on the borders, the keloid is going to come back in a couple of months or years. So it's really, can you put it back, Deborah, please, the other one? This one, you see, it has a lot of redness. So this patient lives in a very distant city. She comes each 3 months maybe, so she's not doing it in a proper way, but anyway, while there is erythema and there is this elevation in the borders, the keloid is going to be back. So it has to continue being treated up to the complete blanching and complete whitening of the borders. And of course, when there is a big keloid and it's treated, in the end, it's going to appear in a larger area, because we actually have a study about that. Everything that goes up spreads, right, when it turns flat. So it's going to occupy a larger area, but it still has to be completely without any erythema. Otherwise, it will probably come back in a couple of months. So this is, for me, very far from resolution. And the patient realizes that. And part of the assessment is performed by the own patient and by the poses, that actually also combine some of the patient's assessment as well.
Thank
you.
How long after the treatment is completed, like how many months afterwards? Or is it just at the end of treatment?
In the end of treatment, and when we see no elevation, no erythema, and we see the blanching of the keloid, we realized the keloid is gone. And we have actually a study about long-term evaluation when we went back to patients that were treated many years ago, like 10 years, 11 years, 12 years ago, and we could see that the recurrence rate, once it's achieved, the complete flattening and the complete absence of erythema, the recurrence is very low. 1.79 was the recurrence rate that we found. It is published in International Journal of Dermatology from last year. Anyway, we are doing a lot of research on keloids, but this one, I can tell you, it's far from the end. It has to be Thank you.
Thanks.